Thank you so much for joining us. I'd like to welcome everyone to the third installment of the Society of Thoracic Surgeons and the Society of Cardiovascular Anesthesiologists webinar series Across the Drapes. Today's webinar is titled Across the Drapes, Multidisciplinary Management and Esophagectomy. Please note this webinar is being recorded and will be available on the STS and SCA websites and STS YouTube channel. At this time, I am pleased to introduce our moderators for this evening, Doctors Gina Lingana and Shubha Chatterjee. Dr. Lingana, let me turn it over to you.
Thank you so much. So excited to be here with everyone tonight for our third installment of Across the Drapes. I'm joined today by my co-moderator, Dr. Shubha Chatterjee from Baylor College of Medicine, and our behind-the-scenes moderator, Dr. Avinash D'Souza from Staten Island University Hospital. Today, we have two great anesthesiologists joining us, Dr. Joshua Cohen from Baylor College of Medicine and Dr. Amanda Schilling from the University of Arizona. Their surgeon counterparts from Baylor are Dr. Sean Groth and Dr. from Baylor, and then Dr. Stephanie Worrell from the University of Arizona. As with our previous webinars, if you have questions that you would like addressed and brought up, we will do our best to get to them all. Please put them in the Q&A. And we will be looking at the Q&A the whole time. And now for her case, I'm going to turn it over to Dr. Chatterjee.
Great. Good evening. So this is a 62-year-old man. Years back, he had a previous colectomy for perforated diverticulitis. He's presenting with a 2 to 3 month history of progressive dysphagia. Went to his gastroenterologist, had an endoscopy, which demonstrated a fungating mass in the distal esophagus. On endoscopic ultrasound, this was staged as T3N1 MX. And finally, on pathology, it came back as moderately differentiated adenocarcinoma. On imaging, preoperatively, he had PET CT scan imaging that you can see a distal mass that lights up. His evaluation included a diagnostic laparoscopy, which did not demonstrate any evidence of distant disease. He subsequently underwent neoadjuvant therapy in the form of chemoradiation. Subsequent PET scan demonstrated decreased FDG avidity, and he was referred to his surgeon for an Ivor Lewis robotic-assisted minimally invasive esophagectomy.
Sounds
Now,
good.
just for background to those who are less familiar, from a surgical standpoint, there are a number of different operations that are available, and we'll get the perspective of our distinguished surgeons. An Ivor Lewis esophagectomy is performed with a chest and abdomen incision with the anastomosis in the chest. A McEwen esophagectomy is a 3 incision with the anastomosis in the neck. A transhiatal is a neck and an abdominal incision with the anastomosis up in the neck. And then finally, you can see one interpretation of a minimally invasive esophagectomy with a number of different camera ports for the chest, as well as something for the abdomen. Next. The conduit can be placed in different locations behind the sternum and behind the mediastinum, and we'll get our surgeons to offer perspectives and what the implications are from an anesthesia standpoint. And with that, we'd like to bring in our distinguished panelists.
So thank you so much to our panelists for joining us. The first thing we want to start in the preoperative phase, and we want to talk about pulmonary function tests. So Dr. Schilling, can you tell us a little bit about your take on pulmonary function tests, when you use them, kind of thresholds you use, when you would want to speak to your surgical colleagues about, hey, I'm worried about one lung ventilation, if that's necessary for the procedure?
Sure. Sure. I'm really lucky that Stephanie really brings optimized patients from that standpoint. They have been frailty scored and everything by the time we get to see them in pre-op. But preoperatively, I do like to see if they respond to bronchodilator therapy the most in the PFTs, because then I can figure out what my rescue algorithm is. And I don't use it necessarily to want to cancel any cases, but mostly to talk about risks, prolonged intubation, and things like that.
Awesome. And Dr. Cohen, are things pretty similar at the University of Arizona or a little different? Or Baylor, sorry, I'm getting you guys confused.
And that's okay. Yeah, we're also very lucky that we get patients that have been, very completely worked up and as optimized as they can be, and patients who are not able to be optimized, don't end up being offered surgery. And so the patients we get are generally in pretty decent shape. If somebody has a heavy history of smoking or COPD, actively takes inhalers on a daily basis, I make sure that they're up to speed with that stuff, that they have taken their inhalers. If I need to give them a breathing treatment up front, I will do that and have the means to do it in the OR as well. And like Amanda said, certain people you can just know they're going to have an increased risk of having to stay intubated for longer after surgery, and I make sure to have those conversations with them.
I think something to add that, we're seeing now is we're getting immunotherapy in the pre-op setting more and more, just starting. And we can see some pneumonitis, which we'd never really seen with chemoradiation. So I think stuff for like Sean and I that look for in like our pre-op clinic to see if we need to change surgical approach.
Right. Let me bring so with part of that assessment is also taking a look at nutrition and sarcopenia and frailty. Dr. Groth, how do you assess nutrition, and then how do you sort of determine whether preoperative nutrition is going to be needed? What's your approach to that in your patients?
So certainly just look at normal clinical factors suggesting malnutrition and get a sense whether or not they can meet their caloric needs by mouth or not, whether it's normal eating or use of protein shakes or other supplements. And if they can't, then we talk about enteric feeding access.
Dr. Worrell, in Tucson, anything, what percentage of the time would you say your patients need some level of, a feeding tube preoperatively to be able to get through, to get ready for surgery?
Yeah, I think it's a pretty controversial topic among surgeons, but I'm a pretty liberal J-tube believer, and that I offer it to most patients when I see them up front if they're having any difficulty, because I know that particularly with FLOT, this like chemo IO, they're going to be it's going to be a lot harder for them. They're going to get really dehydrated, and so I tend to do J-tubes in probably like 70% of the people I see up front.
Okay. Sean, how about in Houston?
Yeah, I'm also very liberal, but it's not quite that high for me. Most people I can kind of coach through with protein shakes and such, but I'm pretty liberal about at the time of esophagectomy placing one if I have any concerns at all.
Okay.
Do you put it? Oh.
No, go ahead. Go ahead.
I was just gonna say, you put it at the time. Are you concerned like for post-op? I always wonder like why people decide to put it after you finish,
Usually concerned post-op if they've been limping through neoadjuvant therapy or any concerns are going to struggle a little bit, somebody a little bit higher risk, low threshold for that. But, if it's somebody who comes in pretty well nourished, maybe it's an early stage cancer that had a positive margin with endoscopic resection, I just have a discussion with them and be like, if probably be okay, but if there's any problems in the post-op setting, if you're not thriving, if you have a leak, any complications, we'll put one in later.
Yeah.
Preoperatively for anesthesia, obviously airway management is something we think about in these cases, both from a dysphagia standpoint and from how we're actually going to manage the airway, whether that be a double lumen tube or a bronchial blocker. Dr. Cohen, can you tell us if you have thoughts about that, if you guys do it particularly one way or the other, or it's patient specific?
I'd say my go-to would be a left-sided double lumen tube. We've had patients before who had airway challenges where that wasn't possible, and we've done a bronchial blocker. But with the right-sided approach to the chest, the bronchial blocker, I'm sure everybody knows sometimes it just doesn't work that great, and so a left-sided double lumen tube I think is the best option.
Dr. Schilling, is that your practice as well?
Yeah, same. We have a robust residency program here, so it's a great chance for the residents to use their double lumen tube. I just personally, I like them to use glide scope to move some of the tissues out of the way, and I use more narcotics so that there's no increase in heart rate because of the possible cardiotoxicity from the FLOT therapy and stuff like that.
No, thank you for that. I wonder if our surgical colleagues have opinions. I've definitely worked with surgical colleagues who have very strong opinions on bronchial blocker versus double lumen tubes, but the COVID pandemic, at least where I had previously worked, made us pivot a little bit from bronchial blocker, from double lumen tube to bronchial blocker. I'm wondering if you guys have any thoughts or kind of that's anesthesia, whatever they do will work with, or if you have opinions. Dr. Worrell, looks like you have an opinion.
Ew. Yeah, no, I actually really dislike blockers for esophagectomies, particularly because your right upper lobe doesn't always get blocked, and that's right when you're doing your anastomosis. That's what's going to be in your way, and I want there to be like nothing in my way as I'm trying to make like my perfect anastomosis. So I like a double lumen. We've actually switched a little bit. I used to feel like leaving a double lumen in for the whole case was too much. And Dr. or Amanda and I have talked about this. We used to go single and then switch to double, and now we just go double right up front.
Um, I want to pretend that we're not living in 2026 and it's like 15 years ago. Josh, let's pretend we're doing open esophagectomies and not minimally invasive. In terms of epidurals or paravertebral blocks, or let's say Dr. Grother's bringing in a new colleague who still does it old school, big and open. How do you, from an anesthesia standpoint, maximize utilize blocks and utilize epidurals, and what's your approach to that in the open setting?
So if somebody's having fully open, that is a laparotomy and a thoracotomy, I think epidural is the way to go. I have a lot of experience with epidurals in my training and in my early years. We do less of them now, but I always enjoy doing epidurals, and I get, a lot of satisfaction from placing a good epidural. And so I'm totally comfortable with it, and I think it's the way to go for open surgery. The problem is, you can't really cover an entire laparotomy and the thoracotomy reliably with an epidural. So you have to kind of plan strategically where you're going to put it and where you want to get the most bang for your buck. I suppose you could cover both, but you would not be very happy because you'd have some pretty troublesome hemodynamic consequences. So I would personally go for an epidural if I had a thoracotomy with a laparotomy. Sometimes we have cases where even now where one side will be, the belly will be open, but the chest will be not, or vice versa. I might consider epidurals in those patients, probably more so for a thoracotomy than a laparotomy.
Okay. Stephanie, do you, in your minimally invasive, do you do anything like cryo block or freeze or anything like that? What are your, what have you found that's worked well?
Yeah. So in the pre-op, and maybe Amanda can mention this because she's more familiar with it. We have a really great pain team, and so they'll do a block up front, and then at the end, I actually do cryo for even minimally invasive for all my chest, just because I don't want them to get pneumonia. Yeah, so I'm trying to give them as best like pain coverage as I can. I don't like epidurals for hemodynamic reasons. I don't think we need them for minimally invasive approaches. But if Amanda wants to comment on the pre-op, that'd be great.
Yeah, I mean, 15 years ago, I can't talk about if erector spinae blocks were available 15 years ago, but that's what predominantly our pain team uses. They do it in pre-op, and it works really well. Our multimodal analgesic approach post-operatively is always limited because we don't have the ability to do oral stuff. And so the erector spinae works really great.
Great. I'm going to use this to transition to sort of the intraoperative phase by first asking Sean. We just mentioned a little bit about different types of esophagectomies, Ivor Lewis, etc. Walk us through, for those who are less familiar, the relative advantages of one versus another and when you use the different techniques.
Sure. So if we just say, your basic gastric pull-up for a distal esophageal cancer, for me, that's going to be an Ivor Lewis. Sometimes pathology, like a more proximal squamous cell, we're not going to get a good margin with an Ivor Lewis, so we'll go to the neck, a McEwen. I'm really not a big fan of transhiatal. I just get better lymph node clearance, even though the survival benefits perhaps a little controversial. If it's going to be not the stomach, it's going to be the colon, I always go to the neck because you just can't get the colon to lie right with a chest anastomosis. You're much more successful going to a neck anastomosis, and a supercharged adrenal graft is always up in the neck. So some of it depends on conduit and the pathology of what we're dealing with.
Okay. Stephanie, your thoughts, and then if you wouldn't mind also commenting on the relative merits of behind the sternum, behind the mediastinum, when do you use what or in what setting on top of the different techniques?
Yeah. So approach is very similar to Sean. One difference, I trained in Michigan with Oringer, so I actually really like a transhaedal. I don't think it's as good a cancer operation, but if I have someone with terrible PFTs or there's a reason I need to stay out of the chest, I feel like it's a really good operation. And then benign disease. So I've done that for some, like burned out esophagus and reasons that you have to take out the esophagus. And then you said to comment.
Rectosternal, posterior mediastinum. Yeah.
So always, I prefer the posterior mediastinum if it's not obliterated, but if they'd had a perforation or I even have one who had like a T fistula as a child and they left the old esophagus there, then I'm not going to drag another conduit through that posterior mediastinum because it might not be possible. So those ones I'll do put behind the sternum.
Great.
Speaking of going into the chest versus not going into the chest, I want to pivot a little bit and talk about ventilation strategies when we are going into the chest and not doing the transhiatal approach. How you guys approach one lung ventilation, if you have any particular strategies. Yeah, Amanda, if you want to start about how you approach one lung ventilation.
Yeah, I'm like neurotic when it comes to one lung ventilation. As soon as the double lumen is in, I will start one lung ventilation while they're prepping and doing everything. And just so I can have a communication with Stephanie and be like, hey, this person can tolerate one lung pretty well, and I think we'll be good for the rest of the case. Within 5-10 minutes, we will know if they're not going to tolerate one lung. And then as soon as I start one lung ventilation, I will start at a higher PEEP, 8 or so, and then reduce my tidal volumes depending on the height of the patient. Say an average size patient, probably 350 or so, and then increase my respiratory rate all the way. And I crank my FiO2 as low as possible. Because personally, I like to have all the exit strategies available. So if the patient starts desatting, I know I have room on my FiO2, I know I have room on my PEEP, and then I can always bleed in oxygen if I need to. But that's all in direct communication with Stephanie. And then I get periodic ABGs to judge and see how we're doing.
Awesome, thank you. Dr. Cohen, do you do anything differently? And then maybe if not, if you could talk us about some of those rescue strategies that Dr. Schilling alluded to and kind of what's your like stepwise progression in terms of maybe we don't need to go right back to two lungs, but we're not tolerating one lung great right now.
Sure. So I don't go immediately to one lung ventilation. I like to get settled and situated. I'll usually, when the drapes go up, I will go to one lung and I just kind of want to see what's going on. Similar to what Amanda said, I like to not have 100% FiO2. I like to maybe go 50 or 60 just to kind of see where we settle out. And just like she said, at that point, if it's going to be an easy day or a long day, basically. And so I like to have some room on the FiO2. I think PEEP is underutilized. I think PEEP can be really, really helpful to just kind of keep that lung inflated while you're turning the tidal volumes down, because I think lung protective ventilation strategy is important to not have tidal volumes that are too big. And then my stepwise approach to hypoxemia on one lung. I think the first question is, how low is too low? And I think that depends on the patient. I think people tend to panic when you start getting in, especially the residents, you get to 94, 93, 92, and they start to get very jittery and they're texting me, I need you to come back. But every patient is a little bit different, and what I tell the residents is you have to think about what is their oxygen carrying capacity. And so if somebody has a good hemoglobin, they should be able to tolerate under anesthesia a lower saturation of 93, 92, even 91 or 90. Some of these people who are heavy smokers probably walk around in the low 90s all the time, and they're fine. And so if we're going down to the 80s, I'm going to start to think about it a little bit more, and I'll maybe increase my FiO2, try to do some recruitments. The last thing I'll do is to try to put some CPAP on the operative side on the right lung. The problem with that is it works really great, but then as soon as the sat starts going up, the surgeon starts asking why the lung is inflating. And so I try not to do that if I don't have to. And typically, rarely do I have to resort to that.
One
Oh, go
One
ahead.
thing that I noticed is if the down lung is still a little bit inflated, if the surgeon can go in and squish that a little bit more, it can decrease your VQ mismatch just enough to kind of help you. So that's a strategy we can use too.
Yeah, a lot of times, the sat will go down to 93, 94 before the lung is totally deflated. And these people have COPD, they have obstructive lung disease. The lung doesn't just collapse automatically. And so it takes the insufflation pressure and it takes surgical manipulation to really make the lung deflate all the way. And as it does, all the pulmonary vasculature will compress and the PVR on that side will go up and you'll have less blood flow into the right lung. And then you're like Amanda said, lower VQ mismatch and your SAT might start to go up a little bit and kind of stabilize.
From Stephanie, nowadays everybody's basically gets some form of neoadjuvant therapy, and it's different than say before. From a surgical standpoint, whether it's adhesions or complexity, um, kind of twofold. One is how do you manage that, and then sort of at a bigger picture level, as you train residents and you train in trainees, in terms of how your approach is that. So it's kind of a twofold question. Some of these are harder operations, but how do you train them?
Yeah. Yeah, so I think it's very evolving field now. So we've gotten pretty used to chemoradiation and some of the scarring that happens with radiation. So I train, as we're doing the abdominal dissection with the radiation, often the pleura sticks to the esophagus. And so, I tell them, be careful. We have to get like good resection margin, but we're going to end up in the left chest and the right chest and manage our hemodynamics while not wanting to put the patient on pressors and ruin our conduit. So it's kind of a lot of things to think about while you're dissecting. I don't see that as much now. We've shifted a lot to just perioperative chemoimmunotherapy. It doesn't stick there as much, but they tend to have a lot bulkier disease and they come in a lot sicker, which is more, now it's Amanda's probably more tough for our anesthesia colleagues because, they're more dehydrated, they're more like malnourished and then we're trying to get them through this big operation. So this, it is a very similar operation, but again, the bulkier nodes with the periop chemo is what I've seen. And so that dissection around the celiac is a little bit more tricky than it used to be because often the radiation didn't go down that low, or sometimes it did, but it didn't really cause that much, I don't know, like that kind of big bulky node we see with the chemo. I don't know, Sean, is that what you've seen too with the
A little bit, though I honestly haven't seen enough of the flot and deflot to really appreciate much of a difference yet.
Yeah,
Yeah.
I think my celiac dissection is very different, is what I've noticed over the last year that things have changed. Yeah.
We have got
Stephanie,
very used to the radiation stuff and the salvage resections after radiation. That it's just something we're kind of gotten used to. Now, I will usually, because of what Stephanie mentioned, leave the mediastinal dissection for the very end of the belly until I'm ready to make the conduits, because if I get in the pleura, it's less of a big deal.
that good. Other from a surgical standpoint, omentum, do you use it routinely? How do you incorporate omentum in your operation, Sean?
For an Ivor Lewis, everybody gets it. I know the data is a little bit mixed, but I want something between the airways and my anastomosis in case a leak festers in that direction. It's not necessarily to prevent a leak, but I think it prevents leaks from being bad and causing dangerous problems.
Okay. Stephanie, similar approach or?
Similar, yeah. It doesn't add much time to the operation. You're already kind of dissecting there. So I do if as long as they have a like pretty good robust omentum, I'm gonna make an omental flap to bring up.
Okay. And the type of stapler, does it matter? Linear, circular, do you have a preference? Does it matter? I mean, are you guys sponsored by specific stapling companies that you kind of wear like a on your jersey? How does that, Stephanie, what are you gonna say?
Yeah, I think this is where
What do you
we're
do?
gonna disagree, but yeah, no, I think well, I do a circular. I do the EEA, which is like it's kind of it is fun teamwork between Amanda and I for that, or her resident sometimes. But so we do the Orville, so they bring the anvil down on an OG tube, and then I bring in the circular stapler and make the anastomosis. And I'm very happy with that technique. So.
Nice. Sean?
I'm still a EEA stapler, but I don't use Orville. I use usually a 28 for a standard Ivor Lewis. Just I've done hundreds of them this way. It works well for me, good outcomes. I think the key is just having a technique that works well for you and doing that well. We had a lot of concerns about Orville causing, crossing staple lines, smaller anastomosis, strictures, that kind of thing. Stephanie has good outcomes, so, nothing wrong with that.
For Sean, for those less familiar, Orville is what?
It's a EA, so it's a circular stapler, but you deliver the part of the anvil down an NG tube rather than put it in and sew it in place. So it's probably a little bit easier to place.
Okay.
I want to jump back to something that Stephanie mentioned. You mentioned we want to avoid pressors if we can, because you're worried about the anastomosis. And I was just wondering if you could expand upon that a little bit, particularly for our anesthesia people who, myself included, um, like all my weapons like at my disposal. So don't love the restrictions, but I would love to hear more from both you and Sean about the importance of it. And like why it matters, like not necessarily like immediately, but in I'm guessing like longer term outcomes. So we can just expand upon that.
Yeah, I think in immediate time, I'm worried about like vasospasm and just like I want to see good like perfusion to my conduit. I want to see the vessels like pulsating. And so the idea of, causing constriction and the pressors, um, I don't really have any data. It really bothers me. So I like lean on fluid. And this is where like Amanda and I will talk a lot. And, sometimes when, we have to be a little flexible because they need to, especially when they're in steep reverse Trendelenburg as we're like doing the abdominal dissection. But I think we try to do fluid. Sometimes we do the high, like we've used that, like
Like the flow track.
yeah,
Yeah.
but
Okay.
yeah.
Yeah, and I guess like along the hypotension side, for the minimally invasive, Amanda or Josh, I wonder if you could talk about when they insufflate the chest, and what hemodynamic changes you're expecting, if you do anything preemptively to mitigate them, and what your communication looks like with your surgical colleagues at that point, if there are problems.
So it's always impressive because sometimes absolutely nothing happens, and sometimes it's just a very, very extreme reaction that's like surprising, and it even surprises me still. And I've been doing this for a while at this point. I think the thing that you might get is just severe hypotension, and I think if a patient is, or that'd be the most common thing is hypotension. I think if a patient is baseline hypovolemic or dehydrated, I think that will just magnify the problem. Especially if you're in the right side of the chest. You're talking about the chest, right? Insufflating the
Yeah, I'm
chest.
talking about, yeah,
Yeah.
no, this is what I wanted you to talk about.
Yeah. So, you're in the right side of the chest, so you put pressure on the IVC, the right side of the heart, potentially, and your just venous return can go way down. And if you're hypovolemic, and if you're, in any bit of reverse Trendelenburg, you're like double hypovolemic, and it magnifies the problem. So I think you have to make sure your positioning is okay. And I try to load patients with some fluid up front if I think they're at a higher risk for being, more hypovolemic. And I like albumin. I know you can have a whole webinar about albumin versus crystalloid, but I like to kind of balance with crystalloid with some colloid as well.
Awesome, thanks. Amanda, is that your practice as well? And feel free to weigh in on the crystalloid versus colloid comment as well.
No, that'll open up debate that's far greater than what I can handle. Our patients come back from pre-op with a 500 cc bag, and I'll just let that bag run through. So they'll get a 500 cc bag in the beginning of the case, and then either I'll get an ABG in pre-op if the resident is able to do a pre-op A-line, or I'll get one right as soon as we intubate. And then I know this is old school, but I'll just trend base access, not as a definite number, but if my base access started off at -2, and then by the time we're head up and we're like -7, I'm going to be like, hey, Stephanie, I think we need some fluids here. Do you mind if I give a bolus? And then it's kind of whatever the choice is at that point, colloid or crystalloid. I'm a big fan of albumin, but I don't want to talk about that.
Um, Going back to from a surgical standpoint, so Stephanie, obviously leak is the most feared complication. So, in terms of what you do in terms of assessing the conduit, whether it's dye, whether it's Doppler studies, what are the most important principles to be able to make sure that it's a tension-free anastomosis, and then what sort of adjuncts do you use to try to help gauge that?
Yeah. So I think it's a lot of little things. So I keep an eye on my gastropoploics when I'm in the abdomen. And if I see them pulsating, that's great. I don't need to use an adjunct there. If I'm concerned at all, if they're like very large and there's a lot of fat in the way and I can't see it, I will sometimes use ICG just to make sure that I see good perfusion. Um, And then when I go into the abdomen, I think one of the most important parts is that you bring it in aligned and don't twist the conduit, particularly minimally invasive. It's much easier to twist. And so I think keeping that all straight. And then again, if I'm putting it together and there's any concern, like I just don't feel like it looks right, I can use ICG there. It's a little problematic if you use it in the belly and then you want to use it in the chest because there may be some kind of residual, might be hard to tell. But yeah, I kind of use it sparingly. So.
Okay. Sean, your approach?
I agree with all those points. So we're talking about a standard Ivor-Lewis gastric pull-up. I actually like ICG in the belly. It just kind of helps me sleep better. But I'll tell you, I'm getting rid of a lot of an excess conduit in the chest. We don't need that much to reach. And so all that stuff is going to go away anyways. And then, right, all Stephanie's points are important. You got to avoid, for functional reasons, avoid bringing excess conduit in the chest where it becomes redundant and then poorly functional. And make sure that staple line is not being twisted as you deliver it into the chest.
Now, Sean, along those lines, I've actually been fortunate because I think over the last 10 years in Houston, I've watched the evolution of this from, in terms of your high volume and success with this. But people who are just starting out, you can still convert to open. So somebody, who's experienced, what are the triggers that you have today? And compare that to the person who's still on the learning curve in terms of whether it's exposure, whether it's whatnot. But what would you say to the person who's still doing their first 10, 20 cases? You know what? This is when you should convert or think about it.
Yeah, I think it's a tough question. I think it's one, you have to be mindful of the time of the patient under anesthesia. And if you're not making progress, there's nothing wrong with opening. It's very safe. I think as I've got more experience, I got more comfortable with more and more complex things like malignant fistulas, perforated esophagus, kind of salvage resections and such. So I'm much more liberal than I was, but we still have patients who just don't tolerate single lung ventilation very well. They need a thoracotomy because maybe it's a perforation that we can't fix. You need to get them off the table.
Okay. Stephanie, who would you advise when you send your trainee out into their first year of practice? When would you tell them you should convert, you should open here?
Yeah, I think the point Sean made are really good. I think also, I started with doing my chest part VATS before I converted to robot. I think that's the hardest part if you're just going out into practice. I think that's totally reasonable to do the chest part open because you need to make sure you find the carina, you feel the carina, you don't injure that. Like I think some early series for robotic esophagectomy, there was a lot of TE fistulas, and I think it's from thermal injury and just not understanding where you were. And so I think it's very safe to do it open, make sure you feel where you are, and to do your anastomosis in a really safe way where you're looking at it. But if you're, and then as you become like a more, experienced robotic surgeon and you're doing lobectomies and esophageal perforations and other stuff, then you can kind of convert over to doing a fully robotic esophagectomy.
Okay.
Yeah, I think that's a good point. I did a lot of that too. I did a fair amount of conventional MIEs before I switched to the robot. And so I would do half one way, half the other way, just kind of helps your psychology and, do one little bits at a time.
Yeah.
Obviously, a conversion from minimally invasive to open surgery is something that both sides of the drapes, as is the name of our webinar series, are going to talk about. This is really for everyone. What are some other critical moments in the operation where you definitely want to make sure there's communication, like, hey, we're about to do this next step, or from an anesthesia side, this is what's going on with the patient. What are some key moments? I'd love to hear from each of you that you want to make sure you communicate to your surgical or anesthesia colleagues.
I can start. I think, the mediastinal dissection, I think, is the time when I'm communicating most, especially robotically. I'm pushing up pretty aggressively on the heart. And so I know I'm already just artificially causing some problems. And then we're heading up to the carina. We're in just like tiger land, and you just want to make sure you're talking to your anesthesiologist. And then that's the time you can get in the pleural on both sides. You can cause like a lot of hemodynamic issues in that dissection. Yeah.
And then I'm talking to Stephanie and telling her, hey, the ABGs look good, the ABGs don't look good, tolerating one lung, not tolerating one lung. And then in like extreme circumstances, if I've given fluids and I can't get the blood pressure up or our urine output's dropping, I'll say, hey, I just might need a little push of something. Are you okay with that to see if we can just get through this? So mostly just hemodynamic changes. And what I'm seeing up top is if there's anything out of the blue, I just tell her if we're trending in the wrong direction ahead of time.
Awesome. Sean, any in addition to what Stephanie said, any other key points of communication for you?
So I think we're always looking at hemodynamics when we start the belly, start the chest. I think that's taken off and when things might change. Um, uh, Asking periodically throughout the course of the operation, especially if it's not an anesthesia attending in the room, what are they making urine? What pressors are you on? What's the base excess like? Because I think sometimes people get a little focused on what they're doing and forget to communicate some of those details. I don't think a little bit of pressure, a little bit of levoped's a bad thing. It's certainly a balance between that and fluid, and just an ongoing discussion throughout the case of balancing fluid needs, not congesting your graft or causing pulmonary injury at the same time, not wanting to cause vasoconstriction that could kill the graft. And then, as Stephanie mentioned, as we're starting to get ready to make the anastomosis, want to make sure that we're ready. We won't have to interrupt ventilation as we're trying to do the most difficult part, at least the most important part of the operation.
Sounds like the anesthesiologists are more in the room in Tucson than in Houston, Josh.
That's not fair. I'm in the room plenty.
I'm kidding. Josh, your thoughts. When are the most important times for communication? When do you want to hear from your surgeon?
I want to hear when something isn't going the way that they want it to be going. When there's a problem, if something is unexpected, that's going to cause there to be a change in the surgical plan. If I'm having trouble with something, I'm, the times that I will kind of speak up and interrupt what Sean is doing are the times when maybe I'm having a kind of a sudden problem with oxygenation or a hemodynamic issue. At this point, I kind of know what the usual culprits are. Are you pushing on the heart? Are you pushing on the cava? Is there a pneumothorax on the left side? Is that a possibility? And if the answer is yes, then we can fix it. If no, I have to try to figure out what else is going on. Um, you know, if I have to give a little dose of pressure here and there, honestly, I think it's totally fine, prior to the anastomosis. Once they're making the anastomosis and after, I'm really trying not to do that unless I absolutely have to. I'm a big proponent of not thinking really in terms of what is the blood pressure, but in thinking in terms of what is my cardiac output and how am I optimizing that? Because when you do that, 98% of the time, the blood pressure is going to be just fine. Um, so, I think you should communicate early and often, because if anything comes up, you just have to talk about it and everyone has to be on the same page.
I'm going to have the surgeons weigh in on one of two questions. So take your pick, Stephanie. So one is the role of gastric emptying procedures. How often, in what setting? And then the second is what would make you revise your anastomosis intraoperatively? What do you see that would make you take it down and redo it? So take one of them and then we'll go from there.
I'll take the easier one. So the first one. Yeah. So for an Ivor Lewis, I actually don't do a pyloric intervention. So I scope at the beginning of the case, make sure the pylorus looks like it's open. If there's any concern, I think about doing Botox. But I think gastric outlet obstruction is pretty easy for me to treat. I do GPOMs, but dumping, I cannot treat, and so I'd rather not have that. But if I'm going to go up to the neck, you do have to do something to the pylorus. That's too far. You need your stomach to empty well. So in the chest, nothing. But if up in the neck, I need to do a pyloromyotomy.
Okay. Sean, anything different on the gastric emptying part or
No,
from your approach?
agreed. Quite honestly, I was taught to dogmatically do a pyloroplasty laparoscopically, and I did that for a long time. But like Stephanie said, it's not needed in most patients, and there is a risk of some bad problems. So like my standard Ivor Lewis, I Botox. I don't do a pyloroplasty, and I also have GPOM in my back pocket. But I agree with her too in that anecdotally, the higher you get with your anastomosis, especially the total laryngopharyngeal esophagectomies, they just don't do well with anything short of a pyloroplasty. At least that's what I've seen.
Okay. What would make you redo it, Sean? What sort of finding or what do you see, whether it's a dye test or just clinical suspicion, what would make you take it down and redo it?
So in the OR, you've just done it. You're going to take it. I've knock on wood, never done that for an Ivor Lewis. Once I fire that stapler, I've committed a lot of stomach. It's going to be very hard to redo it. Once in a while on the neck, you see a small little bubble to suggest a leak when you do a little leak test, and so I might add a stitch or two. Um, Along the whole way, I'm trying to avoid problems, right? As Stephanie mentioned, avoid twisting, making sure things are aligned. You're not bringing up excess conduit. So I think that having to completely take down, redo an anastomosis is pretty unusual. If it was something in the chest, I did an Ivor Lewis, I did an EA, had this happen once, and there was a stapler problem where a donut was incomplete. I put a stent in because I'm not going to be able to redo that and do a better job.
Okay. Stephanie, your thoughts?
Yeah, it's a bad day if that happens
Yeah.
because you've already pulled it up to exactly where you want it, where the tension is really nice down at the diaphragm usually. So if you're redoing it, it's going to be a problem. And I used to, and I do, we always worry sometimes about like proximal margin and stuff, but I always make sure that I'm going to be happy with my margin so that that's not an issue in the OR. So I do that with like the scope and looking at all the pre-op imaging. Um, if I had to redo it, if it was really bad, I may even think of, going to a split fistula and doing something later. Or, I mean, I think Sean's idea of putting a stent in isn't bad. It's very hard. You're going to cause a ton of tension if you try to take down and pull up more stomach, and you're just asking for that to leak later. So, um, yeah, that's a challenge.
Great.
Um, Kind of, in our last 20 minutes, moving a little bit post-operatively, um, this question is for Dr. Cohen. Can you tell us about your extubation strategy for these patients? Does it depend on how they do this case? Do you routinely extubate all of them? Are there certain people you mentioned, both you and Dr. Schilling mentioned that certain patients you're going to talk about the risk of prolonged intubation. So kind of, can you walk us through your extubation end of the case planning?
Um, yeah, so we all know these procedures can be pretty lengthy, and so if it's getting to be 6, 7, 8 o'clock at night, which sometimes it is, we are pretty we're pretty what's the word? I guess we're pretty conservative when it comes to extubation. So we do not extubate these patients. We take them intubated to the ICU, and they stay intubated overnight. And it's just kind of out of an abundance of caution, just because of who is staffing the ICUs at night, and everyone has a horror story about what happened to a patient in the middle of the night in the ICU. So it's just our routine. If there's a patient that's finishing at 3, 4 in the afternoon, I am all for extubating them in the OR if everything has gone well otherwise. For pain control, I can say that we're routinely not doing blocks for these patients, mostly just because we do not have the infrastructure in our institution. We do not have a pain team, like we are the pain team. And so when we have a patient with a catheter, we do some ESP catheters for like minimally invasive robotic heart surgeries that have mini thoracotomies, and so those can work well. But we have to go see them every day, and then if there's a problem in the ICU, the nurses are not that great with them sometimes and don't know how to deal with them, and so it ends up not really being worthwhile because the patient can't get the benefit that they really should get. With that being said, I'm a big proponent of intercostal blocks, and I really like to ask the surgeon to ask Sean to do intercostal blocks in the chest, either on the way in or on the way out. And I think you get a lot of bang for your buck with those. So I do like to extubate when it's appropriate, but we are very willing to leave intubated in a lot of certain situations.
Awesome. And Amanda, is that similar for you? And in addition, I was wondering if you could comment on whether all your esophagectomies go to the ICU, only certain esophagectomies go to the ICU, where they end up, or straight to the PACU.
Okay. Um, I extubate almost all of my esophagectomies. Not to blame the ICU as I'm an intensivist also. But I do extubate and I like to give myself a huge margin of error in the sense that as soon as we go double lung, I increase my PEEP on the ventilator and I reverse early. So the patients are very strong by the time they're ready to extubate. I also, if I need time, will move them to the other bed and have them sitting straight up. And I will make sure that their tidal volumes are enough so they don't have hypercarbic respiratory failure because we can't rescue with BiPAP. And so I give them the largest margin of error in order to be able to, or margin of safety, in order to be able to extubate comfortably. If there's any chance that there is a low PF ratio or they're pulling low tidal volumes and I worry about hypercarbia, I'll stay longer in the OR if I have to, and I'll just watch the end-tidal CO2 and I'll trend it. And if things are looking good, then I'll extubate them on high PEEP and sitting straight up to prevent any atelectasis. And usually they're pretty comfortable. I have them on quite a bit of Dilaudid when I'm extubating. And then they usually go to PACU
Okay.
because they've been extubated. I don't know, Stephanie, how many of I find it very, very, very rare that our esophagectomies go to the ICU intubated.
Yeah, pretty much never, unless there's like unless maybe it's an alternative conduit and it was an open long case, which, are a lot more rare. Then those will sometimes go to the ICU intubated. Yeah. And we are sending our patients after the PACU to the ICU, but they probably could go to a step down unit. We just haven't really committed to changing to that yet. They stay in the ICU overnight. I like to have an anesthesiologist or our, ICU attending in-house overnight, keeping an eye on them.
Amanda, I have a question for you. So are you putting ESP catheters in these patients routinely for the chest?
No, they're just single blocks in the
Just single shot.
beginning and they're done in pre-op.
And what do you put in the block?
Ooh, good question. I think we put Bupi, but
Any additives like Precedex or anything like that?
no, not usually, but I'll have to check with our block team. It's either Bupi or ropivacaine, and I don't think every once in a while they might put a very little Precedex, but just typically straight local.
And
So,
how long do those last, do you think? Any idea?
Um, I think they last at least until the beginning of post-op day one. And we can get them through the night. Because if I'm on in the ICU as an intensivist at night, we're really rarely worrying about the esophagectomies having pain
Okay.
with those ESP blocks. And we know we don't have oral access. And so we really worry about hypercarbonic respiratory failure in the ICU. And I feel like I don't worry about that a lot because the block is working and I don't have to give a lot of narcotic.
So, Amanda, you brought up an interesting point. So, we have typically taken a void BiPAP on esophagectomies, but I have junior intensivist colleagues who, wherever they have trained or practiced, they have said that they would routinely do, 2 to 4 hours, a short run of BiPAP. Is that, do you take it the same way? It's kind of a nuclear avoid BiPAP at all costs, or, how do you guys do you do this that way?
Yeah, I mean, I think BiPAP's evil when it comes to esophagectomies, but I mean, there are times where I'll call Stephanie and be like, "Hey, this patient's really not doing well. I'm not gonna BiPAP them because you have a fresh anastomosis." Because no one can tell. I mean, what if the pressures are really high because someone's not paying attention and they're blowing into their esophagus because of the BiPAP pressures? So I'll just go straight to a tube and
Okay.
I'll intubate early if I'm nervous.
Sean, how do you instruct your ICU colleagues in terms of managing respiratory issues?
I generally don't want BiPAP for that reason. Pressure on the anastomosis, also swallowing air, aspiration. So I think if they're struggling, they need to be intubated.
Yeah.
I agree. I mean, I live by the old saying, if you think about a tube, you should just put a tube. I think BiPAP is I just think it's ill-advised in these patients. I just don't think the benefit outweighs the risk.
Yeah. Um, Another complication that can arise is chylothorax. So, in terms of how do you approach it? When is medical intervention sufficient? When do you need to do something surgically? Stephanie, how do you approach chylothorax?
Yeah, so it can be a real nutritional challenge for these patients. So it starts in the OR. I'm very diligent about any of the branches coming off between the aorta and the spine towards the esophagus. I clip all of them. So you'll see my post-op X-ray has like 100 clips in it. But knock on something, I have had only like one chyle leak. And I went back to the OR really quickly because I don't want them to have continued like malnutrition because then you're just setting yourself up to have your anastomosis break down and for them to not heal anything. So,
Great. Sean, how do you approach chylothorax?
Well, very much so too. I think you got to try to prevent it in the OR. And I was very much like Stephanie before. I was a harmonic user during my conventional VATS days, and I would clip the heck out of everything all the way up. Now with the robotic energy devices, I've been a little bit, I don't know, haven't been using clips as much, and I haven't seen an increase. If I think I've, because of cancer reasons, had to get a better margin, got a little close to where the thoracic duct is at, I'll just prophylactically ligate it.
Okay.
In terms of going back, I think if the output's much more than 500 a day, probably not do very well without intervention. And also agree with going back early too. Just it can be hard to coordinate with interventional radiology to get it done in a timely fashion.
Great. Stephanie, in terms of leak detection on just as a matter of routine, do you get a swallow on everyone? When do you typically get it? When does the NG come out? What's your typical pathway if everything's going well?
Yeah. So I again everything starts in the OR. So I leave a JP drain right next to the anastomosis. I do think that drain amylase helps you identify like small leaks early. And I leave an NG tube. I just leave it overnight. I look at the X-ray in the morning, and as long as the conduit's not full of air, I'm pulling that NG tube out. I don't think it does a lot of good to leave it in for prolonged periods. And then I'm checking drain amylase from that JP every single day. And then I get a swallow on day 5. I know, they're not that sensitive, but I like to know what my anatomy looks like. I like to see things pass through. I like to make sure nothing's hanging up. And it does, it catch the occasional leak, but most of the time you would have suspected that with your JP amylase. So then I'm pulling out my JP the next day, giving them a diet and sending them home on post-op day 6.
Okay. Sean, any major
Um,
differences?
Somewhat similar. I leave a JP too for all for everybody. As long as things are drained, it'll heal 95% of the time, right? And I check my drain amylase. I think it's helpful too. I do day 4, and I also do a day 5 esophagram. Also, I'm not worried about a leak. What I want to look at is making sure the conduit empties before I allow them to eat. So that's my pathway. But I leave their JP in place for 2 weeks. They go home with it usually. Yeah.
Amanda, you mentioned that sometimes you're there overnight in the ICU, and I imagine you work sometimes during the day in the ICU too. What are some red flags that you're looking for post-operatively in these patients that might warrant a call to Stephanie either overnight or on like post-op day 1?
Um, my concern is usually brand new AFib. Or respiratory issues. As far as AFib is concerned, I personally believe it's a sign that something's happening that we need to investigate. And then respiratory issues always. I'm very conservative. If they're even looking like they're trending in the wrong way, I'll use end-tidal CO2, continuously monitor them in the ICU, and if it starts looking like they're tiring out, I'll call Stephanie and we'll tube them right away. But AFib, seeing if they're going septic, things like that. Usually that doesn't happen immediately on post-op day 1. I'm usually worried about respiratory stuff on post-op day like 0 to 1. And then the AFib's a little bit later, and they're usually out of the ICU by then.
Yeah. Speaking of AFib, I mean, I guess kind of Amanda has mentioned it a little outside of the OR, although it can obviously happen in the operating room. For Sean, how are you managing the AFib early, kind of letting it see where it goes? Like, what are your thoughts on managing the post-op AFib?
Certainly having an index of suspicion about a leak if that's of concern at that time, making sure the electrolytes are okay. And then, as we know from the AATS guidelines, amiodarone is our first choice for rate control.
Stephanie, any different thoughts or similar thoughts?
Yeah, so I didn't hear if you said, are you doing any prophylaxis for your AFib?
No, 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 no. Just if they go into AFib, amiodarone is the drug of
Yeah.
choice.
Okay. I will do metoprolol. So if they're like totally not having any hemodynamic issues, I give them PRN metoprolol. And we were talking about switching to DILT, but I think prophylaxis because, you are, like you're right around the atrium, you're irritating everything as you're doing that dissection. So some of that early AFib is really inflammation, edema, fluid from the OR, and not necessarily a leak. So I will do prophylaxis post-op day 1.
Great. Stephanie, when the dreaded phone call, septic, tachycardic, white count, leukocytosis, etc., and you're thinking leak, how do you approach it? When do you send them for CT? When do you just take them to the OR? When do you do an EGD? Walk us through a little bit of your approach and how you'd advise the ICU to approach leak.
Yeah. So they're really sick, I mean, if they're really sick, they got septic really quickly and they got intubated in the ICU, then I can just scope them there in the ICU, which is nice, and I'll put a stent across it. Hopefully, I still have my drain in place, and so that's kind of clued us in, and then that way it's already drained. Sometimes it's not contained by that, and I have to take them back for like a D-cord or something, but that's hopefully happens that way. Otherwise, yeah, I will go to the OR. I don't often because if you have your drain there and you know what it is, I don't always need imaging unless you're concerned about something else going on. I do think a CT esophagram is actually a pretty good study, but often they're too sick to really, swallow the contrast and not aspirate it. So I'll end up just taking them to the OR to drop a scope down and really look at that anastomosis directly.
Okay. Sean, comments and other,
Agree, got to be hyper vigilant. If you're concerned, I put a scope down, very low threshold for that. And I find a CAT scan, if they're stable enough, to be somewhat helpful to look for undrained collections. But once if I'm sure things are drained, I can be a little bit more confident that if they have a leak, that they're going to be okay.
okay. I'm going to shift gears and just take the two that are sort of related to the Q&A. And I'm going to take this to both Amanda and Josh. There's one question on does anybody use methadone? Another on intrathecal morphine as an adjunct to pain. So if you want to, Amanda, if you want to take one or either.
Uh, I'll take the first one, methadone. I don't use a lot of methadone in the OR for long-acting pain control. I do worry about methadone causing hypotension in some of these patients that are already intravascularly depleted. So I just stick to the narcotics that I'm most comfortable with, which is fentanyl up front, high dose, and then Dilaudid towards, the middle end, and then really relying on my block.
Okay. Josh?
Um, I can comment on both. So I've actually never used methadone in IV or oral. We don't have the IV formulation in our hospital, so we can't use IV methadone here. Although I've really heard great things about methadone for lots of different applications. Big spine surgeries, cardiac surgery, belly surgeries, all different kinds of stuff. I would be very interested to try it. Um, I also think intrathecal morphine is great. The only problem with intrathecal morphine is that if you have a patient who is obese or has obstructive sleep apnea, I always learned that intrathecal morphine will hang around for 24 hours or so. And if the patient gets opiates on top of that, you can have a delayed respiratory depression, and they can have a respiratory event like obstruction and hypercapnia, et cetera, which is bad. So I think if you're going to use intrathecal morphine, I think you need to make sure you have like an order set, no opiates without asking somebody, or limited opiates, or whatever. But I think intrathecal morphine works really well.
Do we want to do one more question or do we want to wrap it up there?
Do we have I think that
There was
looks
one
good.
more question in the chat. What is the role of the anesthesiologist in preventing anastomosis leakage? I can answer it quickly if that's okay.
Yeah, yeah, why don't we finish there?
First of all, I would say that remember, it's always anesthesia's fault. So if there's a leak, it's because of anesthesia, but go ahead.
Right. No, that's fair. I think the anesthesiologist role is to be a good steward of the fluids and the pressors. I think it's very easy for the surgeon to say, I don't want any pressors and I don't want you to give too much fluids, but that kind of takes away all the the things that you can use to optimize these patients. So I think you have to just be very mindful of it, and you have to use a balanced technique. I think in our cases we tend to use fluids more heavily than pressors. I think a dose of pressor here and there, honestly, is fine before the anastomosis is made. But I think once the anastomosis is made, and after that, I think you really need to try to be careful and avoid as best you can. So I think the anesthesiologist role in preventing the leak is just to be aware of what's going on and tailor your treatment accordingly.
So to conclude, I'd like each of the four speakers maybe to take 15 to 30 seconds. So the surgeons, if you're talking to the anesthesiologists and the audience, what's a one or two take-home messages you as the surgeon want to convey to the anesthesiologist, and vice versa, you as the anesthesiologist, what's the message you want to convey to the surgeons? Amanda, why don't you begin? What do
Oh,
you want surgeons to know?
um, that I don't know. Stephanie and I are like this. Um, probably that sometimes patients need time for extubation and that we can extubate most patients, just need time and to optimize them as best as possible. And then the very last thing would be it's really hard to do multimodal pain control from an ICU perspective without enteral access, whether that be the J tube. And so we're really struggling with narcotic induced hypercapnia on some of these questionable patients. And so that would be just the other thing I'd like to say.
Great. Stephanie?
Yeah. I think, esophagectomy compared to other thoracic operations is more of a teamwork thing between surgeons and their anesthesiologists, which is why it's great we're doing this series. So I think, like talking like, why is there hypotension? Like, how are we going to manage it? Like what Josh said about the anastomosis, it is really not just us too. It's being good stewards of the fluid and the pressors and making sure that we're really thinking about all of the fine details about it. And that's how we're going to have good outcomes.
Great. Josh, what do you want surgeons to know?
Um, I don't know, esophagectomy has changed. So like when I was a resident fellow, 2012 is when I finished my fellowship. I did a ton of esophagectomies. They were all open, and it's a completely different operation now. Um, and techniques continue to evolve. So I always appreciate communication from the surgeons. And if there's anything that might be different about a patient or unique or problematic, I appreciate just knowing that in advance. And Sean and I and his colleagues also they're very good about doing that, and so I always appreciate that.
Great. Sean, last word. What do you want the anesthesiologists in the audience to keep in mind?
It's a complex operation, a lot of opportunities for morbidity, and it's all a team effort to give that patient the best outcome, both in terms of getting out of the hospital on time and having a good functional outcome. And just the constant communication is important, whether it's patients requiring more pressors, not making urine, or getting hypotensive, hypoxic, whatever. Just the constant back and forth is essential.
Awesome. Well, thank you so much to all of our panelists, and thank you so much for STS and SCA for hosting this webinar series. And now I'm going to turn it over to our SCA and STS education teams for a few announcements. So thank you everyone for joining us tonight, and stay tuned for a few announcements.
On behalf of the STS and SCA, thank you to our SCA and STS moderators and panelists for your participation and insight. If you're not one already, we invite you to become a member of STS. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership or scan the QR code on your screen. Be sure to check out our next webinar at STS, perfusion cannulation and myocardial protection in robotic cardiac surgery, next Thursday, February 19th. And see in front of you some great opportunities and events happening at the Society of Cardiovascular Anesthesiologists, SCA Echo, Thoracic Anesthesia Symposium and Workshops, and SCA Annual Meeting and Workshops happening this spring. Thank you so much again. You'll be able to view the recording next week on sts.org and SCA University, as well as STS On Demand. We wish you a great night and look forward to the next time that we see you. Thank you so much.